First, I'd like to thank the audience, and I'd like to thank Professor Dr. Ines who allowed me to share in this great event. I will discuss today a very small part of rheumatological conditions associated with diabetes, but in a specific form. I'd like to ask about could diabetes be a psychosocial handicap or not? It is a part of my Professor Manel literature, but I will discuss our go in depth. This is my agenda. As introduction, people with diabetes have increased risk of developing a number of serious health problems, while the vascular complications of diabetes are well known to be recognized and account for principal mortality and morbidity from this condition. There is a musculoskeletal disorders which have been associated and cause significant disability. They are very important to be recognized, as Dr. Manel said, and it has a negative impact on quality of life, particularly as many respond to treatment, helping to prevent pain and disability. The severity and risk of musculoskeletal disorders associated with diabetes may inflict both physical and psychological harm on people with diabetes. This is a table of musculoskeletal disorders, which previously said by Professor Dr. Manel. I will only discuss the frozen shoulder or the diabetic shoulder. This is the conditions which affect the shoulder: adhesive capsulitis or frozen shoulder, calcific periarthritis, and reflex sympathetic dystrophy. Why shoulder? The pain and disability associated with the shoulder, as I mentioned, has a very large negative impact on individuals, their families, communities, and healthcare system, affecting daily function and ability to work. It is one of the most common musculoskeletal complaints presenting to rheumatologists and physiotherapy. Psychologically, we usually say shouldering the burden. We need to carry the weight of the world on your shoulders. Engaging in too much negative self-talks, which often means that there is sadness associated with your physical pain. So there is an emotional part of the shoulder, and many studies suggest that people who said these talks or talk about shouldering the burden many times have usually a frozen shoulder. The BMG discussed in 2019 exploring the personal burden of shoulder pain among younger people in Australia. They investigate the well-being, work participation, and productivity, shoulder-related parenting disability over 12 months. This is because of the very importance of the shoulder in our work. The Arthritis Care Research Journal published this study in 2011, which put the measures of the adult shoulder function and compared between them. There is more than 10 measures for the shoulder function only. Quickly, we discuss the quick dash, shoulder pain and disability index, American Shoulder and Elbow Surgeon Society standardization, shoulder assessment form, and etc. There is more than 10 measures to be done. Now go to anatomical background of the shoulder. The shoulder is a ball and socket, highly mobile joint. It consists of the head of the humerus as seen, and the glenoid fossa of the scapula. The glenoid fossa is very shallow, so it allows a very wide range of movement. However, this comes on the impact on the opposite side. The stability of the joint will be affected. So there is very important need for a very competent capsule for this joint to apply the stability, in addition to the rotator cuff muscles, which are 4 muscles producing stability and motion of this mobile joint. One of them, the subscapularis, it appears from the front view, and it is not appeared in this view. The supraspinatus, infraspinatus, teres minor muscle, and there is 2 or more برزة, which is a synovial fluid برزي, and acting as a cushion. عبارة عن وسائد بتمنع friction of the shoulder tendons of the muscles with the shoulder bony parts. This is the types of movement occurring at the shoulder joint, flexion, extension, adduction, internal and external rotation. So it's a very wide range of movement. Regarding the epidemiology, estimates of prevalence of musculoskeletal problems in diabetics varying according to the definition used for these problems and the study population with diabetes, which can ranging from diabetics on an insurance database to primary care cohorts. The report showed that there is a higher prevalence rate, 27.5%, in some studies more or less, but it is more than 20. Of the shoulder joints in patients with diabetics as compared to the rate of 5% found in general population. Unfortunately, women are more likely to develop the diabetic shoulder affections rather than men. Prevalence of adhesive capsulitis of shoulder is 5 times greater in diabetic population than it is in the general population, being identified in 10 to 29% of diabetic population by Zahra et al. The recent study in 2017. Now come to the frozen shoulder, or the main topic of our literature, which is adhesive capsulitis. It is refers to chronic inflammatory conditions characterized by progressive pain, stiffness, limiting mobility, either passive or active motion of the shoulder joint, especially the external rotation and associated with a night pain. The incidence of frozen shoulder is 10 to 20% in type 1 diabetes and 7 to 32% in type 2 diabetes. The incidence of adhesive capsulitis increased with age and the duration of diabetes in both type 1 and type 2. Now, what is the etiology? Still unexplored. It is generally believed that the frozen shoulder developed as a result of perivascular inflammation and fibroblastic proliferation followed by capsular fibrosis and contracture, as a part of the microvascular complications comes from the diabetic complication. I will told later some in advance, or as Professor Dr. Manel said, there is advanced glycation in the product which is sharing in the same problem. It is worth noting the primary frozen shoulder is idiopathic, T-type idiopathic, and there is type of secondary frozen shoulder which may be associated with previous shoulder injury, rotator cuff injury, trauma, or prolonged immobilization. But there is other medical risk factors including past myocardial infarction, retinopathy, and peripheral neuropathy. This is the pathology in which there is an inflammation in the capsule, which will be later on go in fibrosis stage, then in limitation, causing severe limitation of the movement of the joint. The histochemical studies have revealed the presence of fibroblast and heavy proliferation, which leads to chronic inflammatory infiltration comprising muscles and accompanying type 1 type 2 diabetes, type 2 collagen accumulation. This proliferation leads to thickening of the capsule and synovium, capsular contraction, and contraction of the joint cavity. The frozen shoulder passing into 3 stages. The first stage, which is the freezing stage or the stage of pain, it lasts from weeks to 9 months, and it is characterized by diffuse shoulder pain. Then the frozen stage, which is the stiffness stage, in which there is marked progression of the range of motion, and it can persist up to 20 months. The last phase is the thawing phase or reduction phase, which characterized by gradual motion improvement. The pain may regain a functional range of motion of an abnormality. Diagnosis of the shoulder affection or the frozen shoulder, depending mainly on careful examination and history gaining, then investigations. Unfortunately, the plain X-ray will not give us many benefits. However, MRI and musculoskeletal ultrasound can exclude other problems and give very precious diagnostic information. This is a secondary diagnosis for differential diagnosis of secondary frozen shoulder, in which they may be trauma, immobilization, other metabolic conditions like thyroid disease or autoimmune disease and hyperlipidemia, neurological affection in the form of Parkinson's disease and stroke, cardiac diseases, drugs, and malignancy. How to treat the shoulder, the frozen shoulder? The treatment is divided into non-surgical interventions and surgical intervention. The non-surgical, depending mainly on the physical therapy, and non-steroidal anti-inflammatory in the acute phase or the painful stage. Oral corticosteroids of unknown effectiveness, intra-articular corticosteroids, this is in the early phase, have a positive effect on the prognosis, either subacromial or glenohumeral intra-articular injection at least once, but not more than twice within a 3-month period. The surgery is the other option. When the conservative measures fail, we go to the surgical intervention in case of refractory pain or limited motion of abnormality. The physical therapy also improves the functions, range of motion of the shoulder, and the physician-directed home therapy, domestic methods and exercise should be done. The most commonly used secondary care intervention is manipulation under anesthesia, arthroscopic capsular release, and the distension arthrogram, or which is called hydrodilatation. Could it be handicapping? However, several studies have demonstrated long-term pain and shoulder stiffness following a conservative treatment. The long-term disability have been reported in 15%, permanent functional loss in 7 to 15%, and persistent symptoms in 40%. Rotator cuff disease. The rotator cuff muscles, as mentioned, they are 4 muscles which are originating from the scapula and form the tendons that cover the humeral head and providing important dynamic and stability role in the shoulder joint. The risk factors of rotator cuff disease include age, abnormal shoulder joint structure, certain sports and occupations that require excessive overhead activities. The rotator cuff disorders range from simple inflammation to complete tendon tear, which most frequently involving the supraspinatus tendon. This pathogenesis impact both of the capsular fibrosis or the adhesive capsulitis in addition to the conditions of rotator cuff. They are the 3 main factors are chronic inflammation, in presence of impaired circulation, and age-advanced glycation in the product, all of them produced by diabetes, leading to the capsular fibrosis and leading to frozen shoulder. In addition, will lead to structure degradation and functional impairment of the tendons and lead to rotator cuff disease. So they are both are associated diseases. There is no significant correlation of glycated hemoglobin and the frozen shoulder has been reported. دي كانت من الحاجات اللي فاجأتني بصراحة وانا بدور على في المحاضرة. In معظم الستاديز, especially توماس إيتال سنة 2008, showed that significant association between duration of diabetes but not with the hemoglobin A1C. The diagnosis of rotator cuff disease depending on clinical examination and the clinical history taking, imaging studies as ultrasound and MRI, which can confirm the diagnosis and provide further information about severity and the extent of the rotator cuff disease. Conventional radiograph is also helpful for making a more advanced differential diagnosis and to rule out other abnormalities. The management depend on conservative and surgical. برضه بنبدأ conservative زي ما عملنا في الفروزن شولدر, non-steroidal, steroid injection, stretching and strengthening exercise by physiotherapy, then surgical repair, especially if there is complete tear of the rotator cuff will be done. But how to prevent? Although there is no correlation in the studies between the control of diabetes or the glycated hemoglobin and the frozen shoulder, but the advanced glycation in the product is a part of the pathogenesis which is believed to be the cause. And so the blood control will be close to normal as possible. This is one of the preventable causes. Then regular exercise such as yoga, Tai Chi, and other exercises that provides motion for the shoulder joint can help to keep the joints strong and flexible. Now come to another issue after the frozen shoulder, which is calcific periarthritis. The calcific periarthritis is linked to a condition called calcific tendonitis. This is the other name. Most commonly affect a tendon that helps the shoulder move. It can also affect other tendons elsewhere around the body. The calcium deposits, which is hard, sharp crystals, rub against the soft tissue surrounding the joint, causing pain and swelling. The pain from calcific periarthritis does not usually last longer than 4 weeks, but it is unpleasant experience for the patient. Then we come to the reflex sympathetic dystrophy, which is discussed in details by my colleague. It is called also as shoulder-hand syndrome, in which there is pain and swelling in the whole limb. It is associated with vasomotor or pseudomotor changes in the affected limb. There is a group of symptoms including pain and tenderness, swelling of an extremity associated with varying degree of sweating and warmth, maybe coldness or flushing or discoloration and the shiny skin. It is also called the complex regional pain syndrome, causalgia, and Sodex's atrophy. The exact mechanism of how the reflex sympathetic dystrophy develops is poorly understood. However, the irritation and abnormal excitation of the nervous tissue leads to abnormal impulses along the nerves that affect blood vessels and the skin may be postulated. A variety of events can trigger the reflex sympathetic dystrophy, not only the diabetes, like injury, surgery, heart disease, degenerative arthritis of the neck, stroke, shoulder problems, and breast cancer. The response to treatment is greater in the earlier stages of the condition than in the later stages. The prognosis and response to treatment in patients with reflex sympathetic dystrophy is unpredictable. Now come to the conclusion. The diabetic musculoskeletal disorders are important to recognize because of their impact on quality of life, particularly as many respond to treatment, helping to prevent the pain and disability. The shoulder pain is a very common and causes substantial morbidity with negative psychological outcomes. It is recommended to do musculoskeletal examination periodically in the diabetic patient to identify this disorder and to carry out necessary action for prevention of the disorders as soon as possible. Thank you.